Now I invite Dr. Karthik Shukla to deliver his lecture.
But what I understood, or difficult for me to understood, HTO can solve the problem? Sure, is my question to myself. How it is going to solve? When and which spectrum of arthritis it is going to solve? And if we do, then what about the possibilities of longevity and complexities of revision? Reproducibility, expert hand, again it's a technique dependent surgery, and recovery is a question to some patients. Complications and revisions. What I simply put the disease is that osteoarthritis is an intra-articular disease. It's a degeneration of articular cartilage, degeneration of meniscus, fragility of the articular cartilage, along with loose ligaments and gradual degeneration of the anterior cruciate ligament in a very long period of time. But after suffering of all these pathologies for quite long period of time, what we get at the end as a fruit of the suffering is a very strong subchondral bone. And that is what already Dr. Mangal Parihari has mentioned, that there is a very high amount of failure when you do a uni early stage. It is not a time. You must have a very good, strong subchondral bone on which you are going to put your implant. I think since day one, we started uni as a restricted zone. It started with a criteria which was not known decades back. We unfortunately learned this in our textbooks, and over a period of time, the pathology, the word is actually enteromedial osteoarthritis. That does not mean medial compartment osteoarthritis. Both are two different things. So AMOA is the word that goes with uni, not the MCA. But now we have extended, we welcome the surgeons and the patients with a proper indications of uni. We cannot ignore this India, because 60%, 70% of India live in this. This is our population one, with their rituals, hobbies, habits, customs, and their profession as well. We do have another India living along with us, is an urbanized patients with their hobbies, habits, lifestyle. We have young female patients gradually developing osteoarthritis, and we do have obese patients as well to treat. So these are the challenges. So not a single entity in a world can address all the things at a time. But if we put this thing simple, if you have this kind of X-rays on a standing AP view, this is classic. If you have X-rays like this, you have to go for varus stress view. If it is bone on bone, then again it is an indication, otherwise don't go for uni, it is bound to fail for sure. And I personally believe what Dr. Mangal Parihar has mentioned is more extensive osteoarthritis. When we are thinking of TKR, you need a valgus stress view. These are the actually good patients where you do a uni. So not all the time you need all the X-rays. So if you are here, you will have arthritis like this. I think this can be done very well with HTO, and it is too aggressive. This is average, standard AMOA, and this is the extensive AMOA with subchondral scalloping as well. It is just a progression of a disease. If we do a mobile bearing, the things are very easy, highly reproducible. It's just a fear, very simple, that 2 millimeter is loose, and the 4 millimeter will not go in. Now the option is 3, and the 3 millimeter will give you 3 fillings. This is the 0.3 millimeter reproducibility on your fingertips in every single case. It's hard to believe my word, but it is there in every single case. Same with you have to do in the extension. 2 millimeter is loose, 4 millimeter is not going. So if you understand the concept of a mobile bearing, it is a reassurance you have. It's a dual mobility hip you are putting inside the knee. So when you are in trouble in primary hip, you select dual mobility to increase your stability. This is what exactly you do here, and it's a very stable, tissue-friendly surgery. The most important thing is alignment. Uni is not for alignment. It is for intra-articular alignment. automatically because you are not releasing deep MCL. So the real alignment is done by you as a surgeon to align the components inside the knee so that there is no impingement in between the tibia and the poly or the femur and the poly in throughout range of motion. So these x-rays looks horrible actually. So everyone will say it's absolutely a TKR patient. But if you follow it closely with the proper x-rays, this is a patient where you get a wonderful result with a unicondylar knee replacement. If we talk about the robotics that is evolving in uni, what is your planning? So precision, you want to plan it, you want preservation, you want providence, and you want a good performance or functional outcome at the end. And you'll really love to have these x-rays all the time as a post-operative x-rays. So how it is done or how robotics work you to do this is the principles remain same, preserve the tibia because the uni has only one tagline, the tibia is terrible, femur is fantastic. So all your attention should be on the tibia, preserve the subchondral bone, restore the soft tissue tension, under correction, over correction, either is not good. Realign your components in a proper position and achieve the functional, auto-functional alignment by doing a proper surgery. Now with the active robotic, everything can be done through a robotic arm. You have to plan it, execute it accordingly. All your role is to balance the knee, which is very easy in context of TKR because the uni can only be done when we say or proclaim that soft tissue sleeve around the knee is absolutely healthy. It not only prepares the surface, but it also prepares the peg holes accordingly what you have tried. This is all for the technology driven fixed bearing design we are talking about. Mobile bearing uni does not need any technology because it's a gap balancing technology to me. And the most worried part is a tibial part where you have a catastrophic complications like a deep vertical cut, tibial condyle fractures. So this can be taken care by a robotic arm by pre-planned tibial cuts. So at the end you will have a wonderful resected proper surfaces. You put your trials, check the alignments, check the range of motions, your varus angle, you are not over-corrected, you are not overstuffed, and at the end you can do the surgery. This is hard, this is what exactly is needed in our patients. So we have small patients, small bones, our components are size 1 or 2 or sometimes 3. It is auto-aligned software that you can see that is kinematically auto-aligned. You don't need to bother for that. Only thing you have to reproduce the tibial slope from the CT scan. Minimum poly means minimum bone resection. Functional alignment is automatically achieved if you have not violated the rule of the surgery. So we do have faster recovered patients. They are able to do all the things. This is immediate within 1 day. But not all patients are amenable to this, but absolutely this is a very fast recovering because it's a minimally invasive surgery. Now if we talk about profession, these all are teachers. One is yoga teacher, one is a school teacher, one is a dance teacher. She is very obese, but she loves dancing. So if we talk about only one profession, we have a diversified population living in India with different lifestyle. This can be addressed. Obesity we do not longer because it's only compressive forces we have throughout range of motion, but you have not to start with this. It is a little demanding procedure. After some experience, it's good to think about it. This is what I really love. This looks like a TKR patients, but if you see the posteriorly, there is a cupola, which is a sagittal plane stabilizer, which is actually good. It will prevent your anterior cruciate ligament to get damaged. And if you see in a sagittal plane, coronal plane, again the nature will try to protect the knee, and this lateral tibial eminence is preventing tibial subluxations. These are the patients where I really feel the uni is more indicated. This is our all extreme cases we have done uni. This is almost 9 years follow-up. She is doing everything, sitting cross-legged, squatting, doing all household work, and she is back to normal life. So this, I think I completely agree with Dr. Mangal Pariyar that HTO is, see, this is the most important thing I were to deliver. A very well done HTO has served its purpose for 14 years. This is a real case we did recently. Previous HTO is a contraindication of uni, But this is not always. So this is a very well done, we do have patients who has undergone distraction. I really prefer that also rather than even putting plate. Just distract and get it done. You restore the bone stock, and this is the per-operative findings. See, this is the way forward rather than debating. Let's start with the pathology progress is let we evolve from HTO to the uni to the TKR, because any millimeter of bone we preserve is worth preserving, and now we have almost 4 or 5 years that surgery has been done. So I think this is where we are talking about, where you see this knee, it is absolutely most of the time you do TKR in this where the uni should be done. So take home message, results of both procedures are technique dependent, neither can replace either. UKR is evolved with broad but very precise indication and execution due to refined instruments and technology. Well done HTO in an indicated patient by an experienced surgeon can express providence with ease of revision if needed. Like Dr. Mangal Pariyar mentioned, primary TKR can be done very easily even if it is needed in future. UKR is more suitable for patients where TKR is contemplated rather than HTO. And robotics can help to perform UKR better if it evolves with time. That's the message. Thank you.